Welcome to this episode. Today, we're diving deep into pediatric orthopedic nursing essentials, covering immobilization, cast care, traction, congenital skeletal defects, and related conditions. It's a focused discussion for clinicians looking to sharpen their clinical judgment and understanding.
Yeah, it's a solid lineup. We're not just skimming basics here. We're really unpacking the clinical priorities and the rationale behind key assessments and interventions. So let's start with immobilization and cast care. What stands out to you as the absolute priority when assessing a child in a cast?
Without a doubt, neurovascular status, specifically circulation, sensation, and movement, CSM. It's critical because compromised circulation can lead to compartment syndrome, which is limb-threatening. Pain, skin color, and appetite matter, but they're secondary to neurovascular checks.
Right. In delayed capillary refill, anything over 3 seconds is a red flag. That's an emergency because it signals impaired circulation. I think sometimes clinicians might underestimate how quickly this can escalate.
Exactly. And then there's the common issue of itching under the cast. The instinct might be to insert something to scratch, but that's contraindicated due to risk of skin injury and infection.
Yeah, the safest intervention is to use cool air, like from a hairdryer on a cool setting. It soothes the skin without damaging the cast or underlying tissue. It's a simple but often overlooked tip.
Parent teaching is crucial here. They need to check the skin daily around the cast, avoid getting it wet, and report any signs of neurovascular compromise immediately.
And swelling management. Elevate the extremity. Heat or massage can actually worsen swelling or circulation, so those are no-goes.
So the mental model here is clear. Always prioritize circulation and neurovascular integrity over comfort or convenience.
Moving on to traction. What's your take on its primary purpose?
Traction is mainly to align bones and reduce muscle spasms. It's not about increasing mobility or preventing infection.
And for traction to be effective, the pull has to be continuous. Weights must be free-hanging, not resting on the bed or floor.
Right, and knots shouldn't touch pulleys because that disrupts the force vector. Removing weights or allowing slack compromises the therapeutic effect and can worsen alignment or increase spasms.
Hygiene care should be done without removing traction to maintain that continuous pull. It's a good example of how understanding the physics behind traction directly impacts clinical outcomes.
Absolutely. Now, congenital skeletal defects, arthrogryposis is characterized by stiff joints at birth due to muscle abnormalities, which sets it apart from other conditions.
Achondroplasia, on the other hand, is a cartilage growth disorder leading to dwarfism. It's not a muscle disorder or infection.
And osteogenesis imperfecta, OI, is marked by fragile bones prone to fractures, often with blue sclera. Parent teaching here focuses on gentle handling to minimize fracture risk.
That balance between protection and promoting function is tricky. You don't want to encourage rough play, but you also don't want to limit movement excessively.
Exactly. Now, for clubfoot, the first-line treatment is Ponseti serial casting. It's a non-surgical method aiming for a pain-free, functional foot rather than just cosmetic correction.
It requires careful serial manipulation and casting over weeks. Early intervention is key to optimize outcomes.
And while DDH isn't detailed here, it's classically managed with a Pavlik harness, which is good to keep in mind.
On scoliosis, the primary goal is to prevent curve progression, not necessarily to eliminate pain or cure the disease.
Clinical signs like uneven shoulder height and asymmetry in hips are important for early detection and monitoring.
Osteomyelitis presents with localized bone pain and fever, which helps distinguish it from other causes of limb pain.
Priority treatment is intravenous antibiotics. Supportive care like hydration and pain management is important, but antibiotics are the cornerstone.
When it comes to bone tumors, osteosarcoma most commonly affects long bones, especially around the knee.
Ewing sarcoma often presents with systemic infection-like symptoms, such as fever, which can delay diagnosis.
Differentiating these clinically is crucial for timely referral and management.
Juvenile arthritis. Here, the priority is maintaining joint function rather than immobilization.
Nursing interventions include encouraging regular exercise balanced with rest. NSAIDs should be given before activity to reduce inflammation and pain, improving function.
That's a shift from older models that emphasized rest and immobilization.
For systemic lupus erythematosus, SLE is an autoimmune disorder characterized by photosensitivity. Patients must avoid UV light to prevent flares.
Medication adherence and lifestyle modifications are essential given the systemic nature of the disease.
Finally, care planning for immobilized children focuses on preventing complications like skin breakdown and contractures.
Skin integrity is at high risk due to immobility, so frequent repositioning and skin assessments are essential.
Contracture prevention relies on regular range of motion exercises rather than prolonged immobilization.
And emotional support is critical. Encouraging expression of feelings helps mitigate psychological distress.
So, the overarching mental model is to integrate function, prevention, and teaching, not just physical care.
To wrap up, the key takeaways are to prioritize circulation and safety, choose the most complete and safest interventions, and focus care plans on function and prevention.
Understanding the rationale behind assessments and interventions really improves clinical judgment and patient outcomes.
Absolutely. Thanks for joining us in this deep dive. We hope this helps refine your approach to pediatric orthopedic nursing.
Take care.